Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Excited to welcome Dr. Lyndon Cooper. He is an expert in orofacial and dental rehabilitation and oral biology. His research is patient-oriented and focuses on advancing the areas of bone biology, adult stem cell bone regeneration, and the clinical evaluation of dental implant therapies to improve patient care. Cooper earned a dental degree from New York University and a Ph.D. in biochemistry from the University of Rochester. He earned a certificate in prosthodontics from Eastman Dental Center and completed a fellowship at the National Institute of Dental and Craniofacial Research. Prior to joining UIC, Cooper served on the faculty of the University of North Carolina. Welcome, and thank you so much for joining us this morning.
Thank you, Sable. And Uvoh, once again, congratulations on this great program you've run. I hope people arrive today, and what we'd like to do is talk to you about a methodology of planning single-tooth implants that we developed in teaching our undergraduates years ago. What I want to do is make sure that I focus on the simple things today, which are really these rules of 6. If you follow these 6 guidelines for single-tooth restoration in any place in the mouth, you'll find yourself out of trouble. Today, with the limitation of about 50 minutes, we're going to focus on single-tooth anterior implants where I think there's a lot of interest. I'm going to make this move here, if it will. There we go. I'm living in Chicago, this beautiful city that has been quieted by the pandemic, and I teach in the College of Dentistry, and Chicago has a long history of dentistry. It is the home of G.V. Black, and if you take a run to North Street Park, you can see this statue of G.V. Black. The College of Dentistry is my home now, and I am the Dean for Research, where I'm involved in basic science research as well as clinical research. And in fact, as I told Uvoh, I'm going to be rude and depart immediately after my presentation because I've got patients scheduled in the Clinical Research Center from 10 a.m. to 5 p.m. this afternoon. We go, there's the statue of G.V. Black right in North State Park. So G.V. Black is about 10 feet tall here, and it's a very nice place. As I was saying, you know, in our lives, a patient will come into our practice and say, I have a problem with my tooth, and we're talking about the number 10 or tooth 22, and she pulls the tooth out and puts it back in. And of course, the post and the crown have failed, the root is fractured. And you have to appreciate that there's a whole lot more going on aesthetically. But in this case, without going through all the steps and procedures, by using our knowledge of how tissues heal around an implant, we were able to place the implant, perform a crown lengthening, do a provisionalization, all in 1 2-hour visit, and then return 6 weeks later to take a final impression. So by the 3rd visit, we're able to provide these restorations. You notice that the incisal edge position hasn't changed, but we've increased the length of the crowns by approximately 2 millimeters. But what's important to notice is the position of the lateral incisor zenith and the contour of the tissue. This was all done without any periodontal plastic surgery, without any intervening steps, just the knowledge of how tissues heal around an implant. And what I'm going to do is try to show you what we know about this and how we use these rules of 6 to guide implant surgery. Why is this important? What do we know about single-tooth implants? Well, we know that they're very successful. At 10 years, we can have a survival rate of 95% or higher. However, we do know that the implant-supported crown survival is less. And in fact, in your practice, you should expect every 10 years to have at least a 10% failure rate for your implant crowns. Great business if you maintain a good relationship with your patients. We know that there are biological complications, bone loss, and soft tissue complications that are actually rather higher than the implant loss complications. And we also know that there are a variety of technical complications. But what's striking in this paper was that the 5-year aesthetic complication rate was as high as any complication rated for single tooth implants. And it's interesting that people haven't come up with ways of improving the aesthetics of single tooth implants by focusing on what we feel is the most important aspect, and that is implant placement. You can change an abutment, you can change implant design, you can change the material, but if the implant placement is not correct, you'll have major problems. And this is very important. A survey of 1,000 adults demonstrated that oral aesthetics was really important to their life, an advantage of getting a job, an advantage of getting promoted, male or female. Very, very interesting. So if we also think about this, contemporary single tooth therapy often involves very challenging work. It's not my goal to go through all of the steps today, but you'll see them illustrated because often we extract a tooth, place an implant, make a provisional restoration, and come back and deliver a final crown for these patients. And the expectation of the patient is the hard and soft tissue, as well as the materials used to make the crown, replicate that of the opposing natural tooth or the contralateral natural tooth. There are two masters that we have to consider biologically. One is the influence of implant placement on buccal architecture. And the second is the influence of implant placement on interproximal architecture. If we understand how the body responds in these two ways, and we allow the body to do only what it knows how to do without violating its capacity to do this, then we can have great implant success. So we do have concerns for immediate implant placement, although I believe the concerns are the same for even delayed placement. We have issues of implant survival and issues of implant aesthetics. And the problems with implant aesthetics have largely revolved around buccal tissue instability. And I believe that if you pay attention today, I can help you eliminate this problem from your practice forever. So the question becomes, can we control buccal implant tissues? And we have studied this for many years. And one of the examples I'd like to share with you is a paper we published several years ago. We have another paper from a different study coming out just this year that will demonstrate the same result. But we took patients with immediate loaded implants and sockets, immediate loaded implants and healed ridges, and also a separate group published in another paper in grafted sites. And we looked at the response to bone. And if you look at this in extraction sockets, the initial implant contact was 2 millimeters below the implant abutment interface, while in the healed ridges, we approximated the implant abutment interface. What was interesting, the healing process takes at least 3 years. And we see the continual accrual of bone at this implant surface such that by 3 years, the two implant systems, healed ridges versus extraction sockets, are performing the same. And given the way we place the implants, approximating a specific point that I'll describe later, the implants at 5 years show the same biological result. There's no advantage or disadvantage for placing an implant properly in a socket versus a healed ridge when we consider marginal bone levels interproximally. What was also interesting was the change in peri-implant mucosa. When we look at the facial mucosa changes over 5 years for initially the 53 implants and here 43 implants, if you look going along the line here, you'll see that at 5 years there is no change on average in the position of the buccal marginal mucosa at the implant in either extraction sockets or healed ridges. Two very important points. We believe that the risks you take for placing an implant in a socket is not validated by the belief that there's an improved aesthetics. So whenever you place an implant in a socket, you're not doing it for improved aesthetics. You're doing it because the patient would like their tooth immediately. So the other point is that using our implant positioning rules, which you'll hear about in a minute, we have discovered or learned that we can maintain implant tissue stability on the buccal surface of an implant. Now, if we look at this, I'm sorry about this one movement of this word here, I moved computers this morning. About 80 to 85% of the time, we can predict stability. That means at 5 years, most of your implants will show no change in the position of the mucosal zenith, either in an extraction socket or in a healed ridge. What's important, if you look at this, none of these patients experience significant loss of soft tissue. This is 0.5 millimeters, this is 1 millimeter, and then we had 2 patients in the extraction group that lost a considerable amount of tissue, 1.5 millimeters. But if you look at the 157 implants represented in this study, you can see that remarkable success is achieved, and this is largely due to control of implant position. We can take a patient like this, where we understand the rules of biology, and without any significant grafting, and with a simple one-stage surgical procedure followed by an impression in a crown, I can move from here to here based on understanding how this tissue is supposed to heal in a human being and how the interproximal tissues are supposed to heal in a human being. And we know how to do this for extraction sockets, for healed ridges, and for grafted sites. There's similar survival, there are minimal changes in marginal bone levels, and we've noted stability of the zenith. Now, how do we control interproximal peri-implant tissues? Well, you know, this is a very, very well understood issue, but I have to tell you that the most important factor in understanding the control of interproximal tissue is that the level of the connective tissue attachment can be demonstrated clinically and estimated relatively easily by a simple peri-apical radiograph, and the condition of the adjacent tooth connective tissue attachment is the determinant of aesthetics for anterior implants. So we don't worry too much about the buccal condition. We always worry about the interproximal condition. The buccal we can graft, the interproximal we can't. So the principal prognostic factor influencing anterior implant aesthetics is actually the connective tissue attachment of the adjacent teeth. So in your planning for single tooth implants, in your diagnosis for a single tooth implant, I strongly recommend that the first step you take is to use a periodontal probe and a peri-apical radiograph to measure the connective tissue attachment levels at adjacent teeth. If you have one more than a millimeter's loss of connective tissue attachment at the adjacent teeth, you will end up with a deficient aesthetics due to absence of papilla interproximally. Now, vertically, we know this story from the work that's been popularized by Dennis Tarnow over the years, his 5 millimeter description here, which is the distance from the bone crest, which is a good approximation of the proximal tooth connective tissue attachment level, to the contact point. Now recognize that we can move the contact point prosthetically, but this distance of 5 millimeters is very opportunistic, or I should say optimistic view of what is actually available here. When you read the Choquette paper, you'll find that the average is actually much less than 5 millimeters, and this is a good guideline, and we'll talk more about this when we get to the rules of 6. As you can see, they talk about this, and this has been published in another paper by looking at Choquette's drawings here, 5 millimeters between 2 teeth, with 6 millimeters 50% fill, with 7 millimeters complete loss of the papilla, and 4.5 millimeters one can have really remarkable fill. Now, this is important to remember, but the only way you'll understand this is if one actually uses a periodontal probe to measure the distance at the tooth that is to not to be extracted, but the tooth that is to be remaining. Once again, measure at the tooth not to be extracted, but measure at the tooth that is to remain. So there's also the issue of horizontal control of papilla dimension. We've published several papers on this, and I won't go into the details, but today we believe that it is you are equally able to maintain good bone and soft tissue dimensions if an implant with this type of a conical interface with minimal micromotion approximates the adjacent tooth within 1 millimeter. Previously, people believed that this distance needed to be 1.5, or even, according to Lopp's group, 3 millimeters. Of course, trying to use a 3 millimeter rule between two anterior teeth means that you don't have room for a dental implant. One of the other things that I want to make perfectly clear is that what we learned by looking at natural teeth is that the natural anatomy of any tooth interproximally is concave. And this is to create a protective soft tissue barrier between the teeth. And as you see, the distal concavity is always larger than the mesial concavity. But in the anterior area, what I would like to acknowledge is that your abutments must match this form. And we create proximal, concave, interproximal surfaces to account for tight spaces. So we can place a narrow implant and we can place a variety of different size abutments, but if they're not concave, they can begin to encroach. As you see, we can place a 3 millimeter implant, we can place a small abutment, we can place a larger abutment, but if we try to match an abutment that is too broad here, we begin to encroach on the interproximal space. Fortunately, we have customizable abutments and we can really adapt to this. And so what we like to do when possible is we like to use patient-specific abutments where we always design our interproximal surfaces to be markedly concave if possible. This is very important for maintaining that tissue in a biologically relevant and aesthetic dimension. When we build temporary restorations for immediate provisionalization near the implant, here's our titanium cylinder and here's the crown being ready to be screwed into place, we also worry about concavities in the interproximal. And we're very careful to create this space, not filling the space at the time of surgery, but actually allowing for that tissue to form over an 8-week period, maybe even a 12-week period. This allows us to make these crowns. They're very beautiful, but you can see the interproximal is actually concave, not as broad as the facial surface. And this will allow for tissue to grow. The wider the tissue is at the base, the longer the tissue can form. Now, to make this all work, implant position becomes the key factor in limiting complications for single tooth implants. We have to understand where the implant should be placed, not relative only to bone, but relative to soft tissue dimensions. As you will see, we do all of our planning based on the gingival zenith of the tooth to be replaced. Typically, it is the parallel to the contralateral tooth zenith. So if this is the zenith, and we look here, if we don't know what the shape and form of the restorative tooth is to be, then we don't know where the implant can be placed. So it is key to understand what the shape of the restored tooth will be to understand the tooth position. We began our work back in the early 2000s with John Moriarty, and based on a series of objective criteria for dental aesthetics, which were published back in 1979 by Dr. Urs Belzer, we adopted these objective criteria to control implant placement. And what we learned was the gingival health, balance of gingival levels, the zenith, interdental closure, interdental contact, tooth axis, and the basic features of tooth form, and the relative tooth dimensions. The first 7 of these criteria were controlled by the depth of implant placement. So we first learned that what we wanted to do was recapitulate the natural tooth form whenever possible. So if we're going to design an implant crown that is supposed to look like the contralateral tooth, we want the zeniths to match, and then we want the biological conditions to match. And so our goal was always to understand if we could maintain the bone stability, which I've shown you in 85% of the time we can, then the human body only knows how to grow 3 millimeters of tissue across the facial aspect of an implant or the facial aspect of a natural root. It only knows how to grow approximately 4.5 millimeters of tissue interproximally. So with an implant, no matter what you try to create, you're stuck with creating an arc that is basically 1.5 millimeters apical to its extent interproximally, the difference between 4.5 and 3. This will be your prosthetic zenith. Its position is determined by you. The distance between the soft tissue and the bone will be 3 millimeters. So if the bone were here, the only way to create an aesthetic outcome would be to graft to this point. The only way to know this point is to know where the crown is, and I'll show you as we go forward. Now, we objectified this in many ways. You can read this paper if you wish, but let me move forward and tell you that, you know, implant position is really planned relative to the zenith, and the ideal placement to the zenith is what controls implant aesthetics. Now, this is the important slide. The rules of 6 control implant placement and are used to guide you in safe and aesthetic implant placement. The first thing you must have for successful implants is at least 6 millimeters of inter-root or interradicular space. This is important for any implant that's greater than approximately 3.2 millimeters in diameter. When the interradicular space or the mesiodistal spacing is less than 6 millimeters, you either choose orthodontics or you choose a 3 millimeter implant in a space that is larger than 4.5 millimeters. The 6 millimeters of buccal lingual osseous dimension is the limitation for a normal sized implant. When you have less than 6 millimeters of buccal lingual osseous dimension, one should not choose a narrow implant if you have sufficient mesiodistal space. One should choose horizontal augmentation. Now, the 6 millimeter crest to contact point relates to Dr. Tarnow's 5 millimeter rule. Since these are the rules of 6, we felt that a 5 millimeter rule here would be silly. But remember, at 6 millimeters, you have a 50% chance of that papilla being filled. Or another way of looking at it is 50% of the papilla will be filled. And for most patients, except the extreme aesthetic cases, this is not going to create the failure in your practice. And so we say that you cannot be less than 6 millimeters of crest to contact point dimension. The fourth point is very important for posterior teeth, and unfortunately I don't have time to review this today. You must have a minimum of 6 millimeters of interocclusal distance between the implant abutment interface and the opposing tooth. Very important, because we don't make parts smaller than 4.2 millimeters or so to allow for observance of the biological width on the abutment for health, and then creation of a crown above it. The other thing you should know is there are no teeth that are shorter than 6 millimeters. So if you find yourself with this problem, you probably have an extruded tooth opposing this, or you have attrition that needed to be treated in some more comprehensive manner. The fifth rule of 6 is what we call the 3-2 rule, and we include this because 3 and 2, the product of 3 and 2 is 6, and I'll describe that rule to you in some detail in a moment. Let's review. The rules of 6: interradicular space greater than 6 millimeters to allow for the placement of a normal implant with approximately 1 to 1.5 millimeters of bone and tissue between the root and the implant wall. 2. Buccal lingual dimension. You cannot have less than 6 millimeters of buccal lingual dimension and actually place an implant with less than 1 millimeter of bone on the buccal and lingual surfaces. Our feeling is that if we can find sites where implants are placed such that there is always 1 millimeter of bone circumferentially around that implant will survive for quite a while. The next rule is an adaptation of Dr. Tarnow's lesson, and that is we do not ever want to try to place an implant in a site where there is more than 1 millimeter attachment loss, or as it shows here, greater than 6 millimeters of distance from the bony crest to the contact point. Working in conditions where this distance is greater will always result in marked disappointment. And then the fourth rule here is very clear. The distance from the implant abutment interface to the opposing tooth must be greater than 6 millimeters. I can't impress upon you how important this is and how many times I've seen people run into problems. At some point you can make a crown directly here, but then you'll have 2 millimeters of bone loss. As we know that even in the best implant systems, it's very difficult to maintain your bone level approximating the implant abutment interface. Systems like this can do this, but other systems you'll lose 1 to 1.5 millimeters of bone. We don't like to make crown restorations at the bone interface, whether it's at a natural tooth root or a dental implant. Now, moving forward to the 3-2 rule, the most important part of the rule is not just a rule for implant placement, but it's a rule for implant planning that describes the architectural control of dental implant aesthetics. The implant abutment interface should be 3 millimeters apical and 2 millimeters palatal to the planned gingival zenith. It is a planning rule because when we look on our cone beam CT at where the gingival zenith of the crown is, because you'll have a radiopaque marker here, and you measure 3 millimeters up and 2 millimeters palatally, if you do not find bone in this region or near this region, you will likely either have to graft or accept a longer crown length, because over time, the human body will create approximately 3 millimeters of soft tissue apical to the crest of bone on the facial of the tooth. We have published this work in work by Carolina Vera et al. In 2011, demonstrating that we know what this measurement is. Now, it's important to understand that mucosal thickness does affect the implant bone level, and there are many studies who've demonstrated this. This is from Berglund, where they intentionally reduced the thickness of tissue to less than 2 millimeters or had tissue greater than 2 millimeters of thickness. And what they found out was that in sites where it was healed with greater than 2 millimeters of thickness, bone levels were maintained. But where they intentionally reduced the thickness of tissue in beagle dogs, the bone level was reduced, and thus the soft tissue was carried with it, resulting in what would be the exposure clinically of the crown margin. Now, of course, you could reduce the abutment height, but that would lead you with an increased length of your crown or 2 mismatched central incisors, perhaps. There are more studies that support this, and again, we don't have time to go through all the details. This was also done in humans by Benghazi et al., and there are some papers that look at augmentation by Thomas Linkevicius that support the idea that mucosal thickness is important. Now, mucosal thickness is also important for aesthetics. If you think about the thickness facing you, we learned that a statistically significant difference in gingival translucency observed beginning at 1.5 millimeters. One of the reasons we want this implant to displace 2 millimeters from the gingival zenith is to create a thickness of tissue that allows for this aesthetics. And if you look here, you can see that the translucency and the thickness, I think I have this drawn, begins to be problematic below 1 when you have a thickness reduced by 1.5 millimeters. So we recommend this 3-2 rule. We live by this 3-2 rule, and it just takes a matter of time to understand how to work with this in your practice. So as an example, this was done in 2003. It was part of our learning. It was when we realized what we were doing. This patient came in. She's got external root resorption. You can see it's quite profound, except the bone was not affected. You can see the shadow of the bone beneath here. She has a thick biotype, intact buccal plate, no inflammation, a very good site for immediate placement. Good adjacent connective tissue attachments. We've not lost them, but there will be some inevitable bone resorption. So back in the day, we had a different implant system and a different implant driver. The osteotomy was made in a flapless manner, but the implant was placed such that the implant abutment interface was 3 millimeters apical and 2 millimeters palatal to the gingival zenith. And the idea is that over the healing period, that zenith position will not change. So to do this, we also understood that the transition contour of our crown and our abutment had to guide tissue form. And so we understand that from the implant abutment interface, we have a dimension of 3 millimeters to the zenith, and that we have to create the contour of the crown facially, but also create interproximal concavities. And we have done this from this period of time. This is a simple crown made with a bisacryl material. And now you can see 45 minutes after tooth extraction, the implant and abutment is placed, and this crown is simply cemented onto that cementable abutment. If we move 8 weeks later, this is the condition of the soft tissue. The body knows exactly what to do. It's genetically programmed to create that 3 millimeters of tissue, and this tissue is supported by the adjacent teeth. Now, we think that making a good prosthesis also contributes to mucosal stability in several ways. First of all, when you think about this abutment, we have created a matrix for this tissue to form around an abutment. So it offers not only an undisturbed period of biological width formation because the titanium or zirconia abutment is immobile in that conical abutment, but it also offers tissue guidance. But what it also does is it creates tissue stabilization and protection. You see the implant and abutment are in place here, and in this region, an immediate placement or an abutment surgery after one-stage surgery or even second-stage surgery, this gap is filled with a blood clot. And this blood clot will take mesenchymal cells and form the new connective tissue, but they have to be protected. And what we think happens is that the abutment, or rather the crown, maintains this tissue in a very stable manner. This requires that the implant abutment interface is stable without micromotion, that there's no cement in this region, and the crown stays in place. And so this stability and the protection helps to create these contours. I believe one of the worst things for aesthetics is to provisionalize with an Essex retainer where things bounce up and down, create micromotion, and disturb the healing of this tissue. So any fixed restoration, whether it's attached to an implant or the adjacent tooth, such as a bonded pontic, is a very good temporization scheme to protect these tissues. After 8 weeks, we remove the temporary crown and abutment, we make an impression, and the laboratory technician has gone ahead and you can see made a model without a soft tissue moulage. He's marked the implant abutment interface, he's marked the zenith, and he's refined the submucosal contour. Because I spent all this time creating it, I don't want him to remove that contour with a soft tissue moulage. So now he will create an ideal crown contour and keep the margins as shallow as possible. So this is back in the day before we had Emax. In fact, this is one of the first Emax crowns ever pressed in the United States, or milled in the United States, I should say. And now we have our abutment delivered to the patient at 13 weeks, and you can see the beautiful health of the soft tissue. The blunting of the papilla is common to other sites, not necessarily related to the surgery. And now we're able to deliver this by controlling peri-implant mucosal tissues. First, by implant position and provisionalization. Secondly, by not losing the anatomy in our provisionalization in our laboratory phase. And thirdly, by creating an abutment that fits within these tissues and allows for the formation of the crown. So this is the final crown in its place. And you can see that the position of the zenith, a little bit apical to the adjacent tooth, was preserved during the surgery. The abutment is in place, ideally. We have good position. We have good contours relative to the contact points. And so we followed all of the rules, the 3-2 rule, the 6 millimeter rule interproximally. We have 6 millimeters of tissue thickness, and we have at least 6 millimeter interradicular height. And when we follow these rules, we don't run into trouble. So control will begin at implant placement. And please remember, one of the rules is this 3-2 rule, and I'll repeat it again. The implant abutment interface should be placed 3 millimeters apical and 2 millimeters palatal to the planned zenith. So rules are always made to be broken, and people ask me, well, what if it's 4 millimeters? Well, if it's 4 millimeters, you might be okay. You might use a soft tissue graft to account for some of the lost tissue. What if it's 5 millimeters? Then I think you're in real trouble. And doctor, if 2 millimeters is good, is 3 millimeters better? Well, people talk about displacement 3 millimeters palatally, but then you end up with the creation of a very oblique interface, which makes hygiene difficult, number one. Number two is we don't have necessarily the ridge width to place a 4 millimeter implant 3 millimeters displaced from the zenith without protruding through the palatal aspect of the bone. And I've seen this many times where people overreach the palatal displacement. The third reason for not overreaching in palatal displacement, not more than 2.5 millimeters palatally, is we're moving more and more towards screw retention. And screw retained crowns often create a lingual protuberance. And if the implant is placed more than 2 to 3 millimeters palatally, and again, I don't recommend 3 millimeters, we see that the lingual protuberance can actually impede the tongue and create an unaesthetic or an uncomfortable and an unnatural cervical contour, making the tooth uncomfortable and ungainly. So, we go through the process of delivering these crowns in the right position, making the appropriate abutment. And by the way, this can be done after a one-stage surgery as well, and you can get the same soft tissue results, provided you maintain this tissue during the healing period. And again, I want to remind you that this result is important because we can predict this outcome 85% of the time. Now, there are really three global ways to fail with implant placement. The first is placing an implant into a socket with a dehiscence. You see, according to our knowledge, if this dehiscence is not healed, what will happen over time is, in some circumstances, the human body will create 3 millimeters of tissue beyond the bony crest. That means this tissue will continue to recede till it gets to that point. The wider this is, the more likely that will occur. The second mistake is that people used to believe that they should obliterate the socket with a wide implant, or they should support the implant by engaging the buccal plate of bone. This is a real fallacy, and when one places an implant next to bone, the initial response of bone is resorption. And without there being a gap to create blood flow and a blood clot, mesenchymal cell migration and new bone formation, in the absence of that potential, the only thing that will occur is resorption and the absence of bone on the facial surface of the implant. Implants must be displaced palatally. There should be no contact of the implant with the buccal plate of bone for the first 5 or 6 millimeters. And the third and most common problem we see is when the implant is rotated superiorly in the sagittal plane. This happens often, I think, in surgical practice where the patients are laying flat on their back, as some surgeons like to work, and then the implant is then placed underneath the nose. This is the worst situation, and if you should see it, my suggestion is to remove the implant before it heals and start over later. The problem here is that the implant abutment is superior to the gingival zenith, but also buccal to that position. While we can often move abutments up or down, we can't move them back and forth. And so this creates a major problem, and one should always be suspicious of this. Why it matters? Well, this is what's typically referred to me as a problem. You can see a small shadow here, and when it's this flat back, you can see the implant was placed in a buccal position, never really integrated in any way within the alveolus. It was protruding and apically, thin buccal plate resorbs for the reasons I've just mentioned, and now we try to heal it. So after 2 or 3 surgeries, we've gone at least 12 months, and we have an absence of keratinized tissue, we have recession of and loss of connective tissue attachment at the adjacent tooth. This is no longer controllable. This we can always fix. And so the solution becomes one that is mainly prosthetic. New crowns are made on the existing implant. And then actually a full year later, after great disappointment by the surgeon, I created a papilla in plastic composite on the adjacent tooth and then cemented 2 crowns for the patient. Surprisingly, the patient was very happy with this, but this is actually something that can be flossed, but is actually not attainable, maintainable for a long period of time. So we always like to link tooth and mucosal form. I'd like to use this example to demonstrate what I mean by mucosal or zenith planning. This patient comes to us with a perturbed set of mucosal zeniths. There's no symmetry left to right. And if you look at these zeniths, you can see that the real problem is the natural tooth, where the zenith on the lateral incisor is superior to all the other teeth. This requires adjunct therapy with our periodontist, a root coverage procedure. And what we want to also notice is that at the implant site, we don't have an absence of interproximal tissue. We don't have a loss of connective tissue attachment. So as we go forward, we also notice that we have some discrepancies in tooth size that we'll have to address. And we want to make sure that the teeth are all in the right dimension. So the first step involved was a root coverage procedure to reduce the length of the lateral incisor and provisionalize these teeth, giving the patient a slightly longer tooth appearance, but also making all 4 teeth symmetrical left to right. Now that we have the foundation, the question becomes, this central incisor will be an implant. Where does the implant belong? Well, the answer is very simple. It belongs 3 millimeters apical and 2 millimeters palatal to the zenith. We can go through that process by performing the surgery according to the guidance. There is my planned gingival zenith, that bleeding point. And so the implant must be placed 3 millimeters apical to that position. We actually have gone through the process of using a surgical guide, putting the provisional back on to affirm the position, and after the surgery and the provisionalization with the existing temporary restorations, you can see the implant abutment interface, the 3 millimeters of distance, and perhaps you can appreciate in the final crown the displacement of 2 millimeters palatal. You'll also notice the concavity of the final abutment. So we're able to create and maintain these tissue dimensions such that our final restorations, based on the positions of the zenith, based on typical aesthetic commands and decisions, is always one point in space, and that is the gingival zenith, right? And when we do this correctly, we end up with an implant crown that is in 3 dimensions, very, very much similar to the other teeth. Now, if we go back and think about what we said earlier, we knew what the outcome with this would be because 85% of the time I can predict this. No loss of attachment here. And then the other tooth that was very long, we can fix the buccal contour, but we can't completely fix the loss of attachment or the superior position of this tooth in the alveolus. So we have, and we predicted, a slight diminution of the papilla. Not terribly asymmetrical to the other, and I think you might agree that this patient received a beautiful result, again, with the absence of any remarkable effort in terms of provisionalization, impressioning, just allowing the tissue to heal, providing an abutment of the appropriate contour, sitting on an implant in the correct position. Let me spend a few minutes here going through what we consider comprehensive single implant therapy built upon our rules of 6. Our patient presented to a clinic, and I saw this less than optimal anterior 4-unit prosthesis and intervened with the resident and asked if I could please help. And there's several issues here. Again, we have asymmetry here, and we have a tooth that is non-restorable. And so the question becomes, what will happen in this position, and how can we address the asymmetry? So when the provisional restoration is removed, we notice that we have several things that are good about this. One is we have a relative abundance of keratinized tissue. We have a thick biotype, but we have this non-restorable tooth, and we would like not to move that gingival zenith. I would also like to bring this zenith inferiorly by a little trick you'll see in a minute, because the distance from the zenith to the crest is not more than 3 millimeters. I can probably gain tissue here by simply allowing that tissue to heal against a new margin. So what we've done here is we're going to now proceed with implant placement. And again, the key aesthetic prognostic factors are the adjacent tooth connective tissue attachment levels. So what we measure first are the adjacent connective tissue contacts. And you can see the distance from the bony crest on an anesthetized patient to this contact point is 4 millimeters. We will not lose tissue here, we may gain tissue. At the tooth itself, we have a good connective tissue attachment, showing us that the level of bone interproximally here is also in good shape. And then we'll measure facially as well. Now, we begin by releasing the soft tissue very carefully from this and never ever working surgically on the buccal surface of the root. We get all our leverage off the palatal bone, and when the tooth is finally mobilized, we're able to release it without damaging or affecting the buccal tissue. Now that we have this tooth removed, we use a curette to define the intact socket. Finger placed against the buccal surface, curette with a great deal of force is placed against the buccal surface, and we should not feel the curette beneath our finger. It should be protected by bone. So this is the original tooth that was removed. Its caries is removed. You can see the contact point here was very close, the same here. And now we ask ourselves, well, what kind of socket do we have? Elian suggested that there are a variety of different ways of classifying things, and they get worse and worse. And for me, this is my socket classification system. It's either intact and we place an implant, or it's a defect and we do a socket preservation. I think it's very risky to place implants in sockets with dehiscence because we don't know what the impact of the trauma of extraction will be, and we don't know how that tissue will heal. So the best solution for me is to deal with intact sockets in one way, that is, I can place an implant, and then in defective sockets, heal the socket and come back later. So we have an intact socket. We begin our osteotomy with a liniment burr. We move 6 millimeters down the palatal bone in most cases, and we make a purchase. And then we begin our osteotomy. This implant system, the Astrotech system, has a 1.9, 3.1, and 3.7 millimeter step drills. And we are then following, without photograph here of it, we're following the provisional as a guide. Our orientation is such that it will be a cement retained restoration. So the drill apex is at the incisal edge of the tooth, and you can see the displacement here from the buccal surface. The implant here is a micro-threaded implant with a rough surface and a conical interface. And now you can see we are going to place the implant, and we're moving 1, 2, 3 millimeters beyond the gingival zenith. And so the implant is now in resident bone. In this case, the distance to the zenith was actually approximately 4 millimeters, and so we moved that full distance. And now we have the implant in bone, and we're going to consider what happens to the buccal surface. When you extract the tooth and you place the implant, despite placing a graft between the implant and the bone, the buccal plate resorbs. I don't have time to discuss the data behind this, but what we have decided is that we can accommodate for the loss of buccal tissue by performing a soft tissue graft by a tunneling procedure to accommodate for this loss of buccal tissue that occurs at all dental implants. The basis for this was Joe Kahn's work that demonstrated connective tissue grafting at immediate implant placement helped to manage the soft tissue recessions. In the implant system he was using, he found that he was able to use the connective tissue graft to accommodate to the 1 millimeter loss he was seeing before, and his change in marginal bone levels and his gingival zenith levels were now similar to the outcomes we've reported without soft tissue grafting in the vertical dimension. What we were considering now was the horizontal effects. So we know that Thomas Linkevicius has also demonstrated that you can take thin tissue patients and add allograft material, alloderm, and alter the bone loss from 1.5 millimeters to almost no bone loss simply by changing the thickness of tissue in a surgical manner. In this case now, all the patients with thick tissue look like the patients who are grafted, and both of them are different from those who have thin tissue. They repeated this in another study in 2013, again using a different graft material, and again thin tissue patients were different than those who had been augmented with an allograft material. And so we decided we would like to do the same thing. So there's plenty of data to suggest that immediate implant sites, you get better papilla fill and higher marginal mucosal levels when you use a soft tissue connective tissue graft. So our approach is to create a tunnel on the buccal surface and to use a 1.2 millimeter material. This is called perioderm, and we simply pull this through the tunnel on the buccal surface of the bone using a suture. It's a technique that was taught to me by Dr. Homazadeh. Now, that takes care of the tissue surface, and you can see we've now got tissue here. Now, is this important? Well, patients think so. If you look at what happens when patients are followed over time with grafting, with immediate implant placement, from baseline, these are scores divided across the percentage of patients, and then follow-up, you see they actually improve. But what's important to recognize is that if you look at patients' visual analog scale performance, do they like the appearance of their crown versus what the pink aesthetic score and white aesthetic scores are demonstrated by the clinician, there is a very strong correlation between what doctors think about the aesthetics and what patients visualize as aesthetics. So this is very, very important. Now, We also have to graft the gap that's created between the dental implant and the buccal surface of bone. And here we'll be using bio-oss materials because these demineralized bone xenograft materials actually show very low resorption rates. This has been demonstrated in several studies, this one from Mauricio Araujo and Jan Linde, which demonstrated that they're able to preserve this buccal contour with the material when compared to the non-grafted site. One of the limitations of this study is these implants, these human implants placed in dogs, do contact the buccal plate and then favor marked resorption. In this case, we do have a gap, yet we do want to protect that gap with this allograft material. Let me move ahead here. So we're able now to provisionalize the patient, and by reducing the height of the provisional and then using a 12-fluted burr to remove the old margin and placing a new margin a millimeter shorter, we then send the patient home to heal and watch this tissue creep along the surface. And then 8 weeks later, when the patient returns, we find ourselves in a good position. Now, the reason this is stable 8 weeks later is because we followed our rules of 6. We have avoided a facial position, we've avoided dimp implant position, we did not have a bony dehiscence, and we chose the right type of patient. They don't smoke, they don't have a thin biotype. But these rules are very important to the outcome. Now, at 15 weeks, we have our custom abutment back. I've removed the crowns, I've refined the margins, and you can see that the position of the abutment is really in an ideal location relative to the opposing tooth. No intervening surgery, no secondary soft tissue plasty, no special impressions, just good design and good planning. The idea here was to make the abutment fit the system, and so we know what the contours of the crown are, we know what the outcome of the tissue will be. The margins are 0.75 millimeters below the soft tissue margin. You can see this from the lingual as well. And now, I'm sorry, these are rotated. You can see that the preservation of the soft tissue at 15, 17 weeks is remarkable and is something that we believe will be maintained for a long period of time. I then had 4 Emax crowns produced for the lateral and central incisors, and you can see how nicely we have finished the case here for this patient. Good symmetry left to right. Perhaps the crown is a little narrow here, and going back, if I had to do it again, I would have made the abutment wider interproximally. Not here, but at the crown margins, so that the line angles of the crown would have permitted a wider crown here and a wider crown here, specifically in this region where it is deficient compared to the natural tooth. Picking on myself, but that's the only way we get better. So I want to conclude today, and I hope you understand that there are a lot of factors that go into single tooth implant success. But we believe that by controlling the implant placement using these 4 controls for interradicular, buccolingual, crest of contact, and restorative space are essential to providing safe and effective single tooth implant placement. In addition, the 3-2 rule is critical to maintaining the performance of soft tissue. What we're doing is we're matching architecture to biology, providing the right space for the body to do what it knows how to do, adapting the rules from natural teeth to implants and creating an opportunity for the body to perform as it only knows how. Well, Uvoh, you can see I'm enthusiastic about single tooth implants. This is a set of rules that we taught undergraduates at the University of North Carolina to use successfully. And I believe that those of you in practice, if you'll try this a couple times and you'll continue to simplify your approach to single tooth implant therapy, you'll find great success. Uvoh, let me again thank you for creating this remarkable educational opportunity and creating a new social context for dentistry. I really want to applaud you for all you've done, and thank you for letting me join you today.
Thank you so much, Dr. Cooper. This is like, Dr. Cooper, you are my lifelong teacher. So it's always awesome having you. I think this lecture is going to be one of the lectures we're going to have as a foundation dental implant course. There's a course coming And thank you so much. I really appreciate it. If you have any questions, please. Sable.
Yes.
Sable is, I'm going to introduce Dr. Sable Montine. She's coming on board, whether she likes it or not. She's going to be with Dental Webinar Series one way or the other. But Sable, go ahead and coordinate the rest, okay? Right.
Yeah. I was looking for some questions. I did have one question myself, if I may. Just kind of like, have you had any success or anything with the socket shield technique, leaving a little bit of that tooth over there?
So I'm going to be very direct. When I've seen the socket shield technique work, there are two concerns I have. Number one is the people that are doing it are actually working with teeth where the roots are actually in good health. And I question why we would even take that tooth out in the first place. So that's number one. Number two, in following some of the people who jumped on the bandwagon very early with the socket shield technique, some of them remain very positive. But there's another group of those people who are beginning to say, be very cautious about this. And I think if a technique becomes so technically challenging, number one, and number two, requires you to select teeth that probably don't need to be removed in the first place, you probably have a technique that could be used once in a while by someone with great skill, but is not something that we want our 300,000 dentists, 400,000 dentists across the world treating 1 billion people with. So I'm going to step back and say I have no use for socket shield. I've shown that I know how to maintain this. And let me tell you, I can teach everybody who's online or anybody who wanted to learn how to do that simple soft tissue graft with a very inexpensive piece of allograft so you don't have to harvest from the palate. I can teach that to anybody in about 15 minutes. It's something that everyone can learn. Socket shield is really challenging to do well.
Yeah,
So,
I've not done one. I've just, read about it, and yeah, it does seem
people ask me all the time, and I'm very heavy-handed about it. So I think it's something that's interesting. But we do have other ways of managing things, and this seems to work very well, and it's not challenging.
Yes.
All right.
Thank you. And there's another question here. I think, Dr. Cooper, you have a patient to see. And
yes, I've got a minute or two.
Okay, there's one question here. It says you should, can you explain the first rule one more time?
Which rule?
Rule number
First
one.
one, I believe the intraradicular one.
Yeah. So when you have roots, and you want to measure the distance between them, we say that you need at least 6 millimeters of space between two roots. And that may not seem like a lot of space, but if you place a 3.5 millimeter implant between a 6 millimeter space, you still have a millimeter of bone on either side, correct? If the space gets much smaller than 6 millimeters, you really have to go to a 3 millimeter or 2.9 millimeter implant. But, and that's important. And remember, if you have a buccal lingual dimension of less than 6 millimeters, but you have wide interradicular space, you don't use a narrow implant, you graft, because horizontal bone grafting is very successful, right? Which means you're not going to be doing an immediate placement. So again, the interradicular space is just for recognizing that you have to understand how much space you have to work with using conventional sized implants. I think it's the most obvious, but I still see people bumping into root tips and taking the side of a root off from time to time. One thing I didn't get to show you, and I'll come back and do this, is we now use guided surgery for almost every single tooth implant because it precisely puts the implant according to our 3-2 rule, and we can work very effectively in these narrow spaces with the appropriately sized implants. I'm a big fan of guided surgery for the single tooth implant. Okay?
All right, we'll let you get to your patients.
Thanks, Sable. Thanks, Uvoh. Everyone have a really good time. Ralph, I'm sorry I'm not going to be there. Digital design, I think it blends in perfectly. You can tell me where the zenith is, right?
Of course.
Great. You guys have a great day.
Good morning.
Be safe, everyone. Stay healthy.
Thank you. Take care.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator